Welcome to the deep dive. Today, we're really digging into something critical in vascular surgery, graft thrombosis.
Yeah, what happens when those grafts, the ones surgeons carefully put in, suddenly block up?
Exactly. We'll explore why this happens, sometimes right away, sometimes much later, and how surgeons figure it out and deal with it. We're using chapters from a major vascular surgery textbook as our guide here.
And it's a big deal, this graft thrombosis. The book highlights it straight away. It can lead to serious problems, morbidity, losing a limb, even death.
Wow.
Yeah, there's a pretty sobering statistic in there, too. Historically, more than half the patients whose bypass grafts below the knee failed ended up with a major amputation within a year.
That's stark. Really puts it in perspective.
It does.
So our mission today is to kind of unpack the different reasons these grafts fail. We'll look at patient factors, technical stuff.
The whole picture. And importantly, how surgeons check their work right away and what the options are when things do go wrong.
Right. We want to give you a clear, concise overview of what's quite a complex topic.
Okay, so let's start right in the operating room. The surgeons just finished the bypass. The textbook really stresses how vital it is to check the work, the technical adequacy before the patient even leaves the OR.
Okay, yeah, that seems absolutely crucial. So how do they do that? What are those first checks?
Well, the basics are, looking and feeling, inspection and palpation.
Just simple observation.
Pretty much, initially. They'll look closely at the graft itself, any kinks, twists, obvious narrow spots.
Makes sense.
And then they check downstream. How's the target vessel look? Is the tissue getting blood flow back? The foot's perfusion, capillary refill time. Can they feel a pulse down there now?
Okay.
The book even mentions a neat little trick, using clear plastic bags over the sterilely prepped feet so they can easily see the color and perfusion without compromising sterility.
That's clever. But these simple checks, they're not perfect, are they? The chapter points out limitations.
Definitely not foolproof. Feeling for a pulse, it's subjective. Maybe the patient has really calcified arteries.
Hard to feel.
Exactly. Or the anesthesia is still having effects, or there's still some blockage further down. All that can make it tricky to judge just by feel.
And what's this water hammer pulse they mentioned?
Ah, yeah, that's important. It feels like a really strong pulse, like water hitting a wall, but it actually means there might be significant blockage distal to where you're feeling. So a strong pulse doesn't always equal good flow through.
Got it. So touch and sight are the first pass. What else is in the OR toolkit? Ultrasound comes up a lot.
Yes, ultrasound is huge. Very valuable, non-invasive ways to look at things. B-mode ultrasound, for instance. Yeah, it gives you an anatomical picture, like a structural image. Studies showed it's pretty good, comparable to arteriography at ruling out major defects.
Okay.
But here's the interesting part. It's often more sensitive than some types of arteriography at actually finding smaller problems.
Really?
Yep. One study found B-mode picked up defects in 20% of patients during the operation. Half of those needed fixing right then and there. And in that group, where they fixed the issues found on B-mode, there were no early graft failures.
That's a strong case for it.
Yep.
But are there downsides to just B-mode?
There are. Because it's just structure, it can't really tell the difference between, say, fresh clot and flowing blood. They look similar.
Okay.
Plus, the probes are kind of bulky, need sterile covers and gel. It's a bit fiddly in a sterile field. And like a lot of ultrasound, it really depends on who's doing it. Operator skill is key.
Right. Experience matters.
Yeah.
So then there's duplex ultrasound. What's the duplex add?
Duplex adds flow measurement, so you get the anatomical picture and information about how the blood is moving.
Okay, so structure and function.
Exactly. That makes it more powerful. It still has some of the same challenges, probe size, sterility, operator skill.
Sure.
But the big plus is you get Doppler signals, the sound waves bouncing off blood cells, and color imaging. This can highlight areas where blood is moving faster.
Which could mean?
Could mean a narrowing, a stenosis, or some other issue messing with the flow.
So it helps pinpoint problems.
Precisely. It's especially handy for checking the proximal anastomosis, the connection at the start of the graft, if getting an arteriogram catheter there is tough. And it can spot if the flow velocity in the graft is just too low overall.
Which is a bad sign.
Definitely. Arteriography only gives you an indirect sense of flow speed. Duplex measures it. Studies link technical defects found on Duplex with poorer outcomes later.
Any specific measurements?
Yes. One key finding mentioned is low-end diastolic velocity, or EDV. That's the flow speed when the heart's resting.
Okay.
If the EDV is below 5 centimeters per second, that was found to predict early graft failure. Like, if blood isn't flowing well even at rest, the graft's struggling.
That makes intuitive sense.
Yeah. And another study showed using Duplex led to surgeons revising things intraoperatively about 15% of the time, which cut down on early failures.
Pretty compelling. But the chapter mentions some specific grafts where Duplex is tricky.
Right. Newly placed synthetic grafts like PTFE or polyester, air can get trapped in the graft walls.
That messes with the ultrasound waves.
Exactly. Makes it hard to get a clear image. And assessing flow way down in the foot right after surgery can also be tough, maybe due to vessel constriction or existing disease down there.
Okay, so ultrasound, valuable, but with caveats. Now, arteriography. The book calls it the gold standard for anatomy. Why is that?
Well, arteriography, injecting dye, taking x-rays, it's been around a while, and gives a really detailed map of the graft and the arteries downstream. That's its unique strength, seeing the runoff.
The outflow vessels.
Right. Super important if the pre-op pictures weren't totally clear about where the blood could go after the bypass. It shows the whole roadmap.
But it's invasive, isn't it? Potential complications listed.
It is invasive, involves a needle or catheter. So yes, potential risks: intimal injury, dissection, air embolism, kidney issues from the dye, allergic reactions, radiation. That sounds like a lot.
It does.
But the text emphasizes that in large series, the actual complication rate is negligible, really low, especially with experienced teams. And many ORs now have fluoroscopy built in, so it can be pretty quick.
Okay, so how does it work in the OR, generally?
Typically, a small catheter or sheath goes into the graft. Inject maybe 10-30 milliliters of contrast dye.
Okay.
They often temporarily stop the inflow into the graft.
Why?
To keep the contrast concentrated for better pictures. Then they use digital subtraction angiography, DSA.
Extraction?
Yeah, think of it like taking a picture before the dye, then with the dye, and the computer digitally subtracts the before image, leaving just the vessels filled with contrast. Super clear view of the graft and runoff. Figure 48.2 in the source shows a nice before and after.
Cool. And what info does that give the surgeon?
Well, obviously, are the graft and downstream vessels open?
Wow.
Patency. But also, how fast does the contrast clear out? That gives an indirect clue about flow rate and outflow quality.
Okay.
For vein grafts, you check the whole length for defects, twists. For in situ veins, ones left in place, you look for AV fistulas, those abnormal connections.
Right.
For prosthetic grafts, they often check from the far end, the distal anastomosis. Just got to be careful not to mistake air bubbles or like surgical clips for blockages.
Any limitations to arteriography?
Yeah, it's a 2D image fundamentally, so it can sometimes underestimate a stenosis caused by something small, like an intimal flap or some platelets clumped together. Might need different angle shots to see those things clearly.
Okay, that covers the main imaging tools. The chapter also briefly lists some miscellaneous techniques. Can we touch on those?
Sure. Continuous wave Doppler, that's the simple handheld device. Cheap, easy. Listen to flow in the target vessels along the graft.
What are you listening for?
Changes in pitch, like a higher frequency sound or turbulence, might suggest a narrowing, but it's very subjective, depends a lot on the user, not super sensitive. More of a quick screening tool, really.
Gotcha. What about angioscopy, seeing inside?
Exactly that. A tiny, flexible scope with a camera goes right into the artery or graft.
What's that good for?
Especially useful for in situ vein grafts. You can directly see if all the vein valves are properly lysed, opened up. Figure 48.3 shows a valve before and after lysis. Also helps spot any little side branches that weren't tied off and just assess the vein quality overall.
Needs skill, though, presumably.
Oh, yeah. Takes experience to handle the scope safely and effectively. There's some lab evidence suggesting larger scopes might cause a bit of intimal injury with repeated passes, but the long-term significance isn't really nailed down.
And last one, IVUS, intravascular ultrasound.
Right. IVUS is getting used more. Tiny ultrasound probe on a catheter gives a 360-degree view from inside the vessel.
Wow.
Studies show it's very accurate, even for tiny intimal flaps, better than single-plane arteriography in some studies. It's well established for endovascular stuff like stents,
Right.
but its extra value in standard open bypass surgery is still being figured out. Does the extra info justify the cost and time? That's the question.
Okay, so quite an arsenal of tools to check the graft in the OR. But despite all that, grafts still fail. Let's shift to why the pathogenesis of graft thrombosis.
Yeah, it's definitely multifactorial. Even with great technique, early failure within 30 days happens. The rate varies, maybe 0.3% up to 10%, depending on the type of bypass.
And as you said, early failure often has a really poor prognosis, especially for limb salvage.
Absolutely.
The chapter lists a ton of potential contributing factors, patient-related, graft-related.
It's a long list. Patient demographics seem to play a role. Some studies link younger age, African-American race, female sex, obesity to higher risk.
Interesting.
Then there are the risk factors you'd expect. Dialysis dependency often means hypercoagulability. Smoking is always bad news.
Of course.
Comorbidities like diabetes, high platelet counts, high INR, heart failure. The graft itself matters. Prosthetic grafts, very small veins like under 3 millimeter diameter.
More likely to clot.
Tend to be. And where the graft goes matters too. Bypassing to really small arteries in the lower leg or foot like crural or tarsal targets.
More challenging.
Right. Femoral to tibial bypasses, poor runoff in general, vessels that previously had clots, only having one outflow vessel, not being able to pass a small 1 millimeter dilator into the outflow, all increase risk. Even using a vein that needed a lot of fixing up during surgery.
It's complex.
Even anesthesia-type post-op meds can play a part. And one study highlighted that limbs that had a previous failed endovascular attempt, like a stent,
are higher risk for bypass failure later.
Exactly. Higher failure rate for the subsequent bypass.
You mentioned hypercoagulability, blood clotting too easily. Is that becoming a bigger focus?
Yes, it's increasingly recognized, and it might be getting compounded because people are living longer, having more procedures, more exposure to things like heparin.
Which can sometimes paradoxically cause clotting issues.
In some people, yes. That heparin-induced thrombocytopenia, HIT. It's rare, but important.
And even beyond early failure, grafts face challenges long-term. Right.
Oh, definitely. Long-term follow-up shows almost half of reconstructions eventually develop restenosis or occlusion. Wow. Yeah. It really hammers home why ongoing graft surveillance and catching problems early is so critical.
Okay, so let's say a graft is thrombosed. How do surgeons approach fixing it? What's the therapeutic strategy?
First step is detection, obviously. Sometimes it's straightforward, pulse disappears, ischemic symptoms return.
Pain, numbness.
Right. Other times, non-invasive tests like ABI ankle brachial index or Duplex ultrasound are needed to confirm it and figure out where the blockage is. Often you can do this without needing contrast dye initially.
Saving the contrast for potential treatment later.
Exactly. Then, a really crucial assessment is the patient's neurologic status. How bad is the ischemia affecting nerve and muscle function?
Why is that so key?
It dictates urgency. Increasing neurologic deficit from, say, just numbness to actual paralysis means the clock is ticking much faster to restore blood flow and save the limb.
Okay.
The Rutherford classification is a standard way to grade this acute limb ischemia based on sensation, motor function, and Doppler signals. It helps guide how quickly revascularization is needed.
Like different levels need different speeds of action.
Precisely. A completely non-viable limb, unfortunately, means revascularization is contraindicated. But something like Rutherford IB, with significant sensory loss and some motor weakness, needs urgent revascularization.
What about thrombolysis, clot-busting drugs here?
Might be considered for less severe cases, maybe Rutherford the IRI, but usually not right after the original surgery because it takes time to work effectively. And sometimes urgent revascularization isn't needed at all, maybe if the initial reason for the bypass, like tissue loss, has healed, or if it's just recurrent claudication in a patient with lots of other health issues.
Makes sense. So thrombosis confirmed. What's the immediate medical management?
Anticoagulation. Get them on blood thinners right away, usually heparin to stop the clot from getting bigger.
Priority 1.
Yep. Maybe a short pause just to draw blood for hypercoagulability tests before starting the heparin if needed. If surgery with regional anesthesia is planned, systemic heparin might wait until anesthesia is on board. Otherwise, start it systemically.
And then figuring out why it clotted, if it's not obvious.
Absolutely essential. If the cause isn't clear, check the coagulation status, look for those underlying hypercoagulable states we talked about.
Before anticoagulation messes up the tests.
Right. Need that baseline blood draw. Check platelets, activated protein C resistance, anticardiolipin antibodies, antithrombin III, protein S, the standard panel, and always consider prior heparin exposure and potential HIT.
Any other less common causes to think about?
Yeah, things like increased blood viscosity, maybe from dehydration, polycythemia, sepsis, or severe heart failure, usually detectable with basic exams and tests.
And technical errors, still a factor.
Less so for early failure than historically thought, maybe 20% or less now, thanks to better intraoperative assessment. So the suspicion often shifts to other things. inherent graft thrombogenicity, and unrecognized clotting disorder, maybe picking a suboptimal target artery initially.
So it's not always a surgical technique issue anymore.
Not nearly as often as people used to think for those early failures. Studies have flagged specific risk factors too, like below knee or tarsal targets, redo surgeries predicting early failure. And long-term failure predictors include diabetes, pre-op tissue loss, high BMI, needing an early revision.
It's complicated.
Rizatsadlo's review mentioned other high-risk graft situations. Connecting to previously thrombosed arteries, single vessel outflow can't pass that 1 millimeter dilator using a disadvantaged vein.
The chapter brings up 5 elements for durable patency. What are those?
It's a useful concept, basically. Inflow, outflow, the conduit itself, operative technique, and the patient's coagulation profile.
All 5 need be good.
Ideally, yes. Good inflow, pressure, and flow coming into the graft. Good outflow, although that's harder to precisely define or predict just from an angiogram. Even though we know poor runoff is a risk factor, there isn't one perfect angiographic measure that guarantees success. Then the graft material needs to be suitable, the surgery done well, and the patient not overly prone to clotting.
Makes sense. Okay, let's break down treatment based on timing. Early graft failure, 0 to 30 days.
Right. Still happens, maybe 5–10% for infrainguinal vein grafts, despite improvements. The timing within those 30 days is key to figuring out the likely cause.
And as you said, technical error is less likely now.
Accounts for maybe 10% or so because of routine angioscopy, duplex, angiography in the OR. So if the initial check confirmed technical adequacy,
Suspicion shifts elsewhere.
exactly,
Yeah.
to the conduit quality or the runoff quality. And that initial thorough check really helps later decision-making. If you use the only available vein, going to the only possible target, and it looked perfect, then early failure might mean amputation is sadly the best path forward, avoiding more risky, likely futile attempts.
Tough situation. So if early failure happens, what are the immediate treatment options?
The main choices are surgical thrombectomy, physically removing the clot, percutaneous mechanical thrombectomy using devices through the skin, or thrombolysis clot-busting drugs.
How well do they work in this early phase?
Honestly, the results for all of them are generally pretty discouraging in this early period.
Really? Why?
Thrombolysis especially has a high bleeding risk right after surgery. Meta-analyses show a significantly increased risk of major hemorrhage. That often makes it too dangerous.
Okay, so lysis is risky early on. What about long-term success if they do try these methods?
Also not great, unfortunately. For vein grafts treated with thrombolysis after early failure, the 1-year patency rate is low, maybe 15–20%. Plus risks of death, bleeding, thromboembolism, even if the limb is initially saved.
Are prosthetic grafts different?
Slightly better outcomes with lysis, maybe because the runoff is often better in those cases to begin with. But success with lysis seems linked to when the graft failed. Very early failures, especially in diabetics, do poorly. Some studies show basically 0 success for lysis in diabetics with very recent graft failures.
Yeah.
Amputation rates remain high even after technically successful lysis.
What about going in surgically thrombectomy? Better results.
Also disappointing, generally, even if they do a patch angioplasty to fix a suspected narrowing. High rates of the graft narrowing again quickly, likely due to vein damage from the clot itself. Poor 1-year patency rates, high amputation rates.
Is there any situation where surgical exploration works better?
Yes, if a clear technical problem is found and corrected during the exploration, like a missed twist or an incompletely laxative valve. But again, those technical errors are less common now as the primary cause.
So if the initial operation seemed technically perfect and it fails very soon after, what's the usual approach?
Often immediate re-exploration in the OR. The thinking is thrombolysis has extra risks. Bleeding, delay, and poor long-term results here. Surgical thrombectomy plus fixing any subtle issue found gives a better shot, even though, frustratingly, up to half the time, no clear cause is found even during re-exploration.
Okay. And the third option, percutaneous mechanical thrombectomy.
That's the minimally invasive approach, often avoids using acyclic drugs altogether. Different devices work in different ways: suction, water jets, maceration, ultrasound energy. Some, like Angiojet, can deliver tiny targeted doses of TPA, the lytic drug, right at the clot, which might be useful for high bleeding risk patients. Typically do angiography before and after to identify and treat any underlying lesion. Newer devices are getting better at clearing larger clots, which was a limitation before.
So if these early salvage attempts just don't work, what then?
2 main paths. Expectant therapy, just anticoagulation, hope for the best, though amputation is common. Or try a whole new bypass.
A redo bypass.
Yeah, ideally with the best available vein if there's still suitable vein and a decent target artery left. Aggressively attempting a new bypass often gives better long-term limb salvage results.
Even after failures.
Yes. If vein isn't available, maybe prosthetic or cadaveric vein, though results aren't as durable, sometimes you can salvage part of the old graft with thrombectomy and then extend it to a new, better target artery further down. Studies suggest success isn't necessarily tied to the number of previous failures. Aggressive rebypassing can still achieve good limb salvage rates, even in very tough cases.
Okay, let's shift gears to late graft failure, more than 30 days out. How does the approach differ?
A lot of the diagnostics and decisions are similar, but there are key differences. Technical errors from the original surgery, basically off the table as a cause.
Right.
Thrombolytic therapy generally has more utility. It's often a better option now than it was in the first 30 days. But surgically, dissection can be harder because of scar tissue from the first operation.
You said thrombolysis works better later. Why?
The time interval itself seems to be a positive predictor. The longer the graft worked, the better the chance lysis will succeed. The Dartmouth data highlighted graft age being at least a year old, and the patient not having diabetes as critical factors for success with lysis.
So diabetics with late failure still do poorly with lysis?
Generally, yes. Much lower long-term patency after lysis compared to non-diabetics whose grafts worked for at least a year before clotting.
Okay, so let's say lysis is successful in reopening a late failure. Is that usually enough?
Often not. The data shows that after successful lysis for late failure, a large majority, maybe up to 85%, need another procedure, either endovascular or surgical, to keep it open long-term.
Like what kind of procedure?
Things like balloon angioplasty for narrowings, maybe a surgical vein patch angioplasty, or even replacing a segment of the graft in interposition bypass. The results aren't quite as good as treating a graft that's just starting to fail, but still worthwhile.
And endovascular treatments are important here too.
Very important. Angioplasty, maybe stenting, can maintain patency after lysis or treat failing grafts before they clot completely. Especially for prosthetic grafts failing due to progressive disease downstream, percutaneous treatment can extend the graft's life and maybe avoid more open surgery.
If a lesion is found after successful lysis, how do surgeons choose between, say, a patch repair versus replacing a segment with an interposition graft?
It depends on the lesion characteristics, what kind of vein is available if needed, and surgeon preference. Results are often similar either way. You might think vein interposition is better for something like intimal hyperplasia, but it means more in anastomosis, which have their own risks.
If you do need to replace a short segment of vein graft, what's the best source?
Ideally, use leftover vein from the same leg, the remaining ipsilateral greater saphenous or the lesser saphenous. Try to avoid using the big vein from the other leg or an arm vein just for a short patch-up. Save those for potentially bigger future needs.
Makes sense. When is a complete repeat bypass the better option for late failure, rather than lysis and fixing a lesion?
Probably in older grafts with diffuse degeneration, or if a graft fails in a diabetic patient within that first year, lysis is unlikely to give long-term benefit there. A whole new bypass, if feasible with good vein and targets, offers a better shot at sustained patency.
Choosing the vein for that repeat bypass gets tricky if the main one on that leg is gone. Right.
It really does. Historically, the go-to was the contralateral greater saphenous, the vein from the other leg.
But maybe not ideal.
Some studies show higher reintervention rates with those, raising questions. Factors like younger age, diabetes, CAD, a poor ABI in the other leg might predict needing future work. So arm veins are a very reasonable alternative if they look good on ultrasound pre-op.
How do arm veins hold up?
Patency rates can be pretty good, near 70% over 5 years with surveillance and revisions, even if they need more tweaking along the way. Spliced veins from the same leg, lesser saphenous plus leftover greater saphenous, have similar patency to arm veins, but more incisions in an ischemic leg adds risk. Arm veins might mean fewer vein-to-vein connections. Also, using inflow from the profunda artery in the thigh, maybe cleaning out the SFA, can reduce how much vein you actually need.
And the last resort options for repeat bypass below the knee. Cadaveric veins or prosthetic?
Generally reserved for limb threat when nothing else is available. Autogenous arm vein seems to do better than prosthetic grafts below the knee, so preference is always autogenous vein first. Prosthetic is an alternative to amputation. Cadaveric is usually for really extreme cases, maybe with infection or tissue loss, where prosthetic would be too risky.
Wow, we have covered a huge amount of ground today, from checking the graft right after surgery to managing failures months or years later. Any final summarizing thoughts?
I think the key takeaway is that graft thrombosis is still a major hurdle. It really highlights why meticulous technique and thorough assessment, both intraoperatively and postoperatively, are just so crucial. It's clearly multifactorial, and the best approach depends so much on when it fails and the individual patient's circumstances.
And early detection, timely intervention seem paramount.
Absolutely. That's what minimizes those really bad outcomes, especially limb loss.
So, thinking ahead, with all these advancements in assessment, understanding risk factors, what future innovations do you see potentially reducing graft thrombosis further? Is better imaging, better ways to manage clotting risk for each specific patient, maybe even better graft materials? Lots to think about.
Definitely. It's a constantly evolving field, balancing technology, patient factors, and our understanding of vascular biology itself.
It certainly is. Thanks so much for walking us through this complex topic on this deep dive.